A very good morning to one and all. I'm Dr. Sri Brinda, Assistant Professor, Department of Oral and Maxillofacial Surgery, Tagore Dental College and Hospital. The topic of my presentation is the maxillofacial hardware insights on screw systems. I will be talking about the introduction, observatives, principles, fixation techniques, screws in oral and maxillofacial surgery, literature review, discussion, and conclusion. The primary etiology of maxillofacial fractures is road traffic accidents. The most important treatment modality is open reduction and internal fixation that restores the compromised form and function of the maxillofacial region. Therefore, appropriate fixation technique determines the prognosis. The main objective of this review is to understand the types and functions of the screws used in ORIF, to explore the design features influencing the clinical outcomes, to review indications and techniques specific to maxillofacial fractures. The principles of open reduction and internal fixation, as given by AO in 1958, are anatomic reduction of the fracture segments, stable fixation, preservation of blood supply of both soft tissues and bone, and followed by early and active mobilization. The role of screws in rigid fixation act by clamping the bone plate and bone together. These screws provide rigid internal fixation, allow for early mobilization and healing. They can be used alone as in lax screws or with plates, example mini plates. In maxillofacial surgery, the interest in rigid fixation began with the treatment of fractures of edentulous mandible, as the fracture created in these segments were easier to manage. The screw is inserted in a neutral zone. As the low screw is fully inserted, the screw and the bone move towards the fracture, compressing it. With further tightening of the low screws causes tension in the plate and compresses the fracture evenly across the full diameter of the bone. The structure of a screw has an external or the outer diameter and an internal diameter or the core diameter. The pitch of the screw is calculated from parallel to the screw axis from a point of one thread to the adjacent thread. The distance between the core and the external diameter is the thread depth. The diameter and length of screw affects the pull-out strength. The thread pitch influences the grip and bore purchase. The material of the screw determines the biocompatibility and corrosion resistance. The commonly used are stainless steel and titanium. The head types of the screw varies from hex, cruciform, or star-shaped. The technique for screw insertion begins with drilling with a pilot drill, followed by insertion of the screw either manually or power-driven. The principles of screw fixation must be kept in mind to avoid neurovascular structures. Types of screws used in rigid fixation are positional screws that hold the fragments without compression, lax screws that create compression between the bone and fragments, and locking screws that lock into the plate to form a fixed angle construct. It is based on the principle of neutralizing unfavorable traction strains while at the same time allowing transmission of favorable compression forces, and providing adequate stability, allowing direct bony union called as functional stable fixation. Lat screws are primarily used to prevent rotational movements of the fracture fragments. The lag screw relies on the principle of compression. The screw compresses the surface when it glides through the cortex of one fragment and engages the cortex of the opposite fragment. Lag screws are primarily selected in patients having sufficient bone available for placement of two screws. The screws are placed in direction perpendicular to the line of fracture. The advantages include absolute rigid fixation, less hardware, hence cost effective, quick and easy to use, and accurate reduction. Coming to the locking screws, these screws gets locked within the plate and thus stabilizes the bone segments without compressing the bone to the plate. It's simple to use and requires less time due to less bending and faster application with good results. There are two designs of locking systems, that is threaded locking plates and tapered. The tapered system is a new generation that facilitates more flexible locking mechanism and allows screw angulation of up to 10 degrees. Based on the relationship with the bone, there are monocortical screws and bicortical screws. Monocortical screws are placed involving the single cortex and the chances of damage to the vital structures are less. whereas the bicortical screws involve both the cortices and are usually used at the lower border of the mandible. Coming to the recent advances, there are self-tapping and self-drilling screws. The self-tapping screws are inserted into a pre-drilled hole without tapping a screw head, whereas the self-drilling screw has a drill-shaped point at the tip to cut the bone and does not require pre-drilling. In recent times, bioresorbable plating systems have been introduced. These plates and screws stabilize the fracture segments long enough for the fracture healing to occur and dissolve by themselves. Most commonly, polylactic acid is used in bioresorbable plates that dissolve by the process of protein degeneration and hydrolysis. This bioresorbable plating system is effectively used in low load bearing areas of the maxillofacial skeleton. The disadvantages are it requires pre tapping of the screw and it is comparatively expensive than the conventional. The complications of the maxillofacial hardware are screw loosening or breakage, thermal osteonecrosis if overheating during the drilling procedure, infection or soft tissue irritation. Proper torque and angulation are critical aspects in determining the proper prognosis of the hardware. Many literature reviews speak about the complications of the maxillofacial hardware. One such review from the Journal of Craniomaxillofacial Trauma Reconstruction speaks about the indications for salvage versus removal of the maxillofacial hardware. The authors presented data on complications and or hardware removal. They provided an algorithm for the management of hardware complications. In case of infection, the main parameter considered is bony union. If there is only soft tissue involvement, then irrigation followed by debridement and plate retention was followed. In case of obvious bone involvement, the debridement was followed by hardware removal was considered. And if the only tooth involvement was there, extraction of the offending tooth followed by irritation of the hardware system gave better prognosis. Another prospective clinical trial from the Journal of Maxillofacial and Oral Surgery depicts the use of two lag screws for the fixation of sagittal split fracture of the mandibular condyles. All the patients were evaluated with parameters like mouth opening, occlusion, pain, deviation of the mandible. They concluded that by saying that two lag screws for the fixation of sagittal split mandibular condylar fractures is recommended to prevent the rotation of fractured segment and for more stable fixation. In this review, I would state that open reduction and internal fixation with the use of screws either alone or in combination with mini plates or reconstruction plates remains the gold standard of rigid fixation. Lag screws are used for interfragmentary compression. Positional screws maintain the spatial relationship without compression, and locking screws provide enhanced stability in comminuted or atrophic mandibles by minimizing plate to bone contact and reducing the screw loosening. Factors such as screw diameter, length, thread pitch, and material composition influence fixation strength and healing. Advances in screw technology, including self-drilling and self-tapping designs, have simplified surgical protocols and improved the outcomes. In conclusion, screws are vital in open reduction and internal fixation for facial fracture management. A thorough understanding of the mandibular anatomy, fracture biomechanics, and fixation principles is essential for achieving optimal results and minimizing the complications such as infection, malocclusion, or hardware failure. Therefore, mastery of technique leads to improved outcomes. I would like to acknowledge my references. I thank my Department of Oral and Maxillofacial Surgery, Tagore Dental College and Hospital, for guiding me through this presentation, and I thank the organizers for giving me these opportunities in this forum. Thank you for the patient listening.